Hello everyone, my name is Dr. Rahul Goyal. I am the Clinical Executive at Elsevier Clinical Solutions. I also practice as a GP and in the urgent care setting in the northwest of England. And today we have with us Dr. Claire Mallinson. Claire, please can you introduce yourself to the audience.
Hello, my name is Dr Claire Mallinson and I'm a consultant anaesthetist and also the Director of Education at King's Health Partners, which is an academic health science centre. So very lucky to have a portfolio career where one can enhance the other.
Thank you very much. I'll start with the training bit, if that's okay. Given your experience training doctors and developing training programs in the NHS, what excites you and at the same time what concerns you about incorporating AI into medical education and your own clinical practice and the trainees' clinical practice? And how might these technologies address some of the current challenges facing the NHS?
Well, I'm enormously privileged to work with people that are on a training pathway, and this is in many specialties. And what we have to realise is that people are using AI in their own normal personal lives, and so we have to really ensure that those technologies and abilities are also available to us, not just in the future, but in the near future. So hopefully very soon, and it is there. And so we have to really gain the confidence. And perhaps what I've really enjoyed is the fact that as people coming through, there can be real positive disruptors in this field. And fortunately, I've got leaders in my organisation that love to have people coming through their training, sitting alongside them, having discussions, and to be really open to what's coming through. In many organisations, the brightest and best sit next to the chief executives, and we don't often do that in healthcare, and we kind of have a bit of a real streamline, and you have to climb the ladder rung by rung. So I think it's really good at being a positive disruptor, not just in decision making, but also in how we organise healthcare. And we have to really emphasise to our colleagues that are still kind of coming through their training the true potential of AI in health and social care as well, particularly early detection. We've only just heard about AI being used in screening methodologies. We can think about image analysis, which is really quite advanced now. But also personalised treatment, thinking about some of the complex situations that we end up now with our patients, and to really personalise treatment. And we're going to need all the data and to use AI so that we can create the best care for each of our patients. We're so used to protocols, and if you have high blood pressure, this is the care you go along. If you've got something else, this is diabetes, this is what you go along. But what about somebody who's got 2 or 3 things? Then we need to really personalise treatment, and this is where we can use data and AI. Operational efficiency. So many of us are doing things that you don't need to be trained as a highly paid healthcare practitioner to do. So we should be using AI to do all that background stuff in the So what about discharge summaries? What about some of the typing that we're doing? A lot of the operational efficiency should be taken away from that day-to-day grind to enable all of us to spend more time with our patients. So that patient engagement is really key to what we do. And of course, clinical decision support with the complexity of cases that we now have. And in my field of complex paediatric spinal deformity work, you might have somebody who you've only ever seen one case of a syndrome. And so it's really helpful to use technology and data and really looking into those clinical decision making. So it's not taking away the final decision, but to make sure that you've gathered all the information that is truly available. And of course, we've all got so much pressure of work now. So the administrative workflow, not just in healthcare, but for example, in HR and you know how patients are admitted and pre-op assessed, etc. All of these can be enabled. This is not taking away from the clinical decision maker, and we know that it's not AI that will take over, but we will be using AI to make our patients better. And we have to do some public and patient engagement with this. And I think one of the exciting things about using AI is that we can work with colleagues in our academic health science centres, in other faculties, not just in healthcare, not just in science and engineering, but in ethics, in the other humanities, and to think broadly about how society is changing. And as we use AI without much information or knowledge in other areas of our lives, in healthcare, there will be a particular desire to make sure that we're getting this right, because we have no room for mistakes. So AI will enable us to be better at care. It will not be just taking over.
Thanks, Claire. You know, we talk a lot about digital natives and digital nomads. So it's safe to say that we both are nomads. We've moved in to the digital world, and then we have colleagues who are born with a smartphone in their hand, who are the digital natives. You know, you are fortunate to work very closely with trainee doctors and young medics, the digital natives of the world, if you like. How urgent, what's the level of urgency you feel as a leader in the education field in medicine, that we need to enable these digital natives and the digital nomads with the right tools to give them the confidence to do their work better?
So, as much as they are digital nomads in that they've always had the opportunity to use this, not all of them are confident in the creation of this work. So we have to, you know, what I'm really enjoying is almost a hackathon where we get engineers with the doctors and nurses and healthcare workers to really ensure that we, you know, kind of look at the problems we've got and work with the people that can actually help us to create the solutions. What we don't want is people to create solutions to a problem that we never realised we had, or maybe we don't have a problem. So I think we've got to be careful and really co-create this work. But certainly I was with one of my foundation doctors, and he'd done an intercalated BSc in computer science. We should be really engaging with those that are interested. So just like we look at research, as we look at leadership and management and education, we've got to utilise those people that are interested and engaged to be the leaders in this area. So not everybody's going to be an expert in everything. We never want that. We're a broad church. We want people to flourish in the areas that they're engaged with. And so it's really exciting to have people like that where we can work with them. And certainly in my department of anaesthetics, we've got a couple of people who've really worked with our systems so that they are putting in upgrades and all sorts of tools so that we're using technology in a way where we don't have to build it from the beginning. But what we can do is inform the quality improvement of this work all the time. So it's about the engagement, making sure a few people have the opportunity and the career opportunity to have a portfolio career, so that they're the ones that are co-creating the solutions. So as much as we feel that maybe the younger generation have got all the answers, we might be surprised that there are some people that are older. So I think we haven't. We can create, we don't want to create tribes of different, those that have and those that haven't. And I think one thing we can say about AI and data and the use of technology is that it should really share the load and the burden, and be a true democracy for all of our workers to really have access to amazing information to enable the best patient care.
Thank you, Claire. That's very insightful. So, lastly, what challenges does the NHS face? What is stopping it from implementing AI, and what challenges are there? Not just AI, Gen AI, and new technologies, uh, both in healthcare delivery and the medical education part.
So it is this holy grail of health, you and the one-to-one feeling that everybody has the right to that kind of one piece of that one professional for them. But I think as we get more of our healthcare on our phones, on our apps, etc., we can really engage with the public in a different way. And it's the fear. So what we do need to do is make sure that we are creating confidence, because the competence is there, the capability is there. But what we do need to do is really make sure that we're enabling people to be engaged so that they're not fearful. And there are some, holy grails out there that people expect, but maybe patients will demand more, so that will make us react in a way. And people have already Googled their information before they even come and visit their health professional. So we have to be ready for that, and to engage and to work with patients in a way that fits with their modern lives.
It's interesting you mentioned the patient aspect of it, because I have used Clinical Key AI a couple of times to get an answer for a question I have, but equally to try and convince a patient of the best course of treatment based on the best evidence available. And that has really helped me, almost akin to getting a second opinion within the room that I am with the patient. So that is really a very powerful tool, and thanks for surfacing that back up. Um, Thank you very much, Claire. Again, a pleasure to get insights from a leader in both the clinical and the medical training field.